Welcome to Board Pearls. This is episode 1 of 5 of the chronic pancreatitis, cysts, and neoplasms chapter in the pancreatic and biliary disease module. This episode is the chronic pancreatitis framework, how it's classified by cause, the genetic forms, and where each one breaks trypsin control, how it's diagnosed as the disease advances, and how the pain is managed, including the shift that moved early surgery ahead of endoscopy and dilated duct disease. Chronic pancreatitis is a fibroinflammatory disease that ends with the acinar cells replaced by scar, the ducts distorted and calcified, and both the endocrine and exocrine function gone. The finding that clinches it structurally is parenchymal calcification, and the functional consequences are exocrine insufficiency and pancreatogenic diabetes. Recurrent acute pancreatitis precedes the chronic form in a majority of cases, but only a minority of patients with recurrent acute disease ever progress, which is the first thing the framework has to explain. Why this patient and not that one? The mechanistic answer the board's test is that exposure alone is rarely enough, because a toxic exposure has to find a co-modifier before fibrosis takes hold. Fewer than 3% of heavy alcohol users develop chronic pancreatitis, and that number is the entry point to the whole framework, because if the overwhelming majority of heavy drinkers escape, something else has to be doing the converting. The dominant co-modifier is tobacco, which markedly accelerates progression and may be the single strongest driver of the move from acute to chronic disease, so smokers have more atrophy, more pseudocysts, and more severe pain than non-smokers with the same alcohol exposure, and a genetic background modifier is the substrate on which that alcohol-tobacco synergy plays out, which is why two patients with identical exposure histories can end up with completely different glands. The etiologic classification built on this is captured by the mnemonic TIGAR-O, standing for toxic metabolic, idiopathic, genetic, autoimmune, recurrent severe acute pancreatitis, and obstructive. The Western patient sits mostly in the toxic metabolic group, with alcohol the largest contributor, tobacco next, and hypercalcemia and chronic kidney disease as secondary contributors. Idiopathic disease splits into early onset, late onset, and tropical forms. The genetic causes are a handful of genes we'll come back to. Autoimmune disease is its two types, which live in a later episode. The recurrent severe acute category is the patient whose repeated acute episodes have left behind enough fibrosis to count as chronic. And the obstructive category is structural blockage-producing back pressure pancreatitis, and it contains the must-not-miss of the chapter, which is pancreatic adenocarcinoma. A patient over 50 with a first idiopathic acute pancreatitis episode may be a patient whose tumor obstructed the duct and produced that episode as its presenting event. And the temptation under stem pressure is to blame alcohol or call it idiopathic and move on, when the correct move is cross-sectional imaging follow-up once the inflammation settles, because missing a cancer presenting through obstruction is the exact failure mode the framework is built to avoid. The obstructive category also covers strictures from prior injury, ampullary tumors, and pancreas divisum, with divisum likely contributing only in genetically predisposed patients. There's a separate severity classification, M and HIME, that tracks clinical stage, pain, complications, and glandular dysfunction separately, and it's more useful for research than for the bedside, but the discipline it carries is tracking each of those separately rather than collapsing severity into one number. The genetic causes deserve their own walk, because each gene breaks a different part of trypsin regulation, and the inheritance, penetrance, and phenotype all follow from where in the pathway it sits. Trypsinogen is the inactive precursor. Trypsin is the active enzyme that cleaves the rest of the digestive enzyme pool, and intrapancreatic trypsin activity has to be tightly controlled because uncontrolled activation drives autodigestion, so the gland has 3 layers of defense. The trypsinogen molecule is built so that self-activation is rare. One inhibitor blocks the small amount of trypsin that does activate inside the gland, and a second enzyme cleaves and inactivates trypsin as a backup if that inhibitor is overwhelmed. Each genetic form attacks one of these. The cationic trypsinogen gene, when mutated, produces a trypsinogen that escapes inactivation and generates excess intrapancreatic trypsin, so it's a gain of function that drives recurrent autodigestion from the inside out, inherited dominantly with high penetrance, with symptoms starting in the second decade, and a phenotype of recurrent acute attacks giving way to relentless progressive chronic disease. Its critical feature is the cancer risk, the highest of any chronic pancreatitis subset, which is why it's the only one for which routine surveillance imaging is recommended, with annual MRI alternating with endoscopic ultrasound starting at age 40. The inhibitor gene works on the same pathway in the opposite direction. Loss of function removes a brake rather than adding an accelerator, so its phenotype is permissive rather than dominant, found in a small fraction of healthy people, a larger fraction of idiopathic chronic pancreatitis, and a substantial fraction of tropical pancreatitis, meaning a carrier without a co-modifier may never develop disease, while a carrier who drinks or smokes converts exposure to fibrosis at a far higher rate. The chloride channel gene acts at a different node because it drives ductal bicarbonate secretion, and impaired secretion means the duct can't flush its own enzymes, inherited recessively across an enormous variant spectrum, where milder variants give isolated chronic pancreatitis with a pancreatic-sufficient phenotype and no pulmonary or sweat chloride findings, so a patient can carry a meaningful contribution to disease without full cystic fibrosis. The remaining two genes are modifiers, one through impaired backup trypsin degradation and one through the calcium-driven activation pathway that also underlies hypercalcemic pancreatitis. Genetic testing is indicated when the cause is unclear, when there's a family history, or when onset is young, under about 35, and the reason isn't academic. Etiologic clarity sharpens the counseling on alcohol and tobacco because a carrier who smokes is converting exposure to fibrosis far faster than a non-carrier. It identifies the patient who needs cancer surveillance, and it identifies at-risk family members. Diagnosing established disease is the next problem, and there is no single accurate biomarker, histology is rarely available, and the imaging findings depend on stage, so the workup is calibrated to how advanced the disease is, because the structural change one test sees early can be invisible to another. Pain is the dominant symptom in most patients over the disease course, epigastric, radiating to the back, and often after meals because food stimulates the pancreas, and about half of the painless patients still have exocrine or endocrine dysfunction at presentation, which is why functional testing has a place even when pain is absent. The first imaging test is contrast CT, and the reason it's first is parenchymal calcification, the finding that clinches the diagnosis, which CT shows better than anything else, while also distinguishing pancreatic calcium from gastroduodenal or splenic vascular calcification that a report could otherwise misattribute, with the known limitation that CT can be entirely normal in early minimal change disease before calcification develops. When CT is normal but suspicion stays high, the next test is secretin-enhanced MRCP, because standard MRCP shows the ducts without contrast injection, while adding secretin drives bicarbonate-rich secretion that distends the duct and transiently fills the side branches. So a minimal change patient with subtle side branch dilation that plain MRCP missed becomes visible, which makes it the favored test for early disease when CT and standard MRCP are normal. Endoscopic ultrasound sits at the high-resolution end, using the Rosemont criteria, which weight parenchymal and ductal features as major or minor and grade the gland from consistent with chronic pancreatitis down through suggestive, indeterminate, and normal, with parenchymal features like hyperechoic foci with shadowing, strands, lobulation, and cysts, and ductal features like an irregular or hyperechoic main duct, dilated side branches, and intraductal calcifications, and its advantages showing parenchymal texture without contrast injection at the lowest procedural risk of the high-resolution ERCP with the Cambridge classification used to be diagnostic but no longer is, because it carries a real post-procedure pancreatitis risk. Its grading agreement is poor, and endoscopic ultrasound gives comparable information without contrast, so ERCP in chronic pancreatitis is now reserved for therapy. Functional testing complements imaging but can't establish the diagnosis on its own. Fecal elastase is the most available exocrine test with a value below 200 micrograms per gram of stool as the loose threshold, though it has a high false positive rate in diarrhea because dilution drops the apparent concentration and a cutoff below 100 improves specificity at the cost of sensitivity. The 72-hour fecal fat collection is the reference standard for quantifying steatorrhea but is cumbersome and confounded by mucosal disease and rapid transit. And the most sensitive test for early disease is secretin-stimulated endoscopic pancreatic function testing, where secretin stimulates ductal bicarbonate output, and a peak duodenal bicarbonate at or above 80 milliequivalents per liter has high negative predictive value. So failure to reach it indicates ductal cell dysfunction even when imaging is entirely normal, which is exactly the gap early diagnosis needs to fill for the patient with a normal CT and MRCP but real symptoms. So the sequence is CT first for calcification, secretin MRCP next for the duct and side branches, endoscopic ultrasound for minimal change parenchyma, and functional testing alongside to catch the gland whose function has dropped before its structure has, with ERCP reserved for therapy. Pain management is the last piece, and its structure mirrors the disease because the pain is multifactorial. Parenchymal inflammation drives a baseline signal, fluid collections add pressure, ductal obstruction from stones, strictures, or a head mass produces back pressure, and over time neural sensitization and central reorganization remap the input so the brain reads normal signals as pain. Pain pattern correlates poorly with imaging, which is why a normal-looking pancreas doesn't exclude debilitating pain, and a heavily calcified gland doesn't mandate it. Alcohol-related disease produces more pain than other causes. Pain is independent of disease duration, and there are no reliable predictors of who responds to intervention, which is why management advances step by step rather than jumping to the definitive option. The foundation is alcohol and tobacco cessation, because ongoing exposure perpetuates the fibroinflammatory drive and will undo anything layered on top, so this is not a gentle suggestion. Non-opioid analgesics come first because they target inflammation without adding dependence, with a role for both acetaminophen and NSAIDs. Neuromodulators are added next because they target the neural sensitization that explains why pain tracks so poorly with imaging, typically gabapentin or pregabalin, with tricyclics or serotonergic agents as alternatives. Enzyme replacement is added when exocrine insufficiency is also present, because delivering lipase to the duodenum provides negative feedback on the hormone that drives pancreatic stimulation, so its small effect on pain becomes meaningful when insufficiency is concurrent, though it isn't primary pain therapy without insufficiency. Antioxidant evidence is mixed and hasn't become standard, and narcotics are minimized because of dependence, induced central sensitization, and dysmotility. When medical management fails and the disease is obstructive, the next move depends on the ductal anatomy. An endoscopic ultrasound-guided celiac plexus block transiently interrupts visceral efferent signaling and helps about half of patients for a limited time without addressing the parenchymal driver, so it's a palliative bridge rather than a definitive treatment. Endoscopic decompression comes next, meaning pancreatic sphincterotomy, stricture dilation with stenting, and shockwave lithotripsy for stones larger than 5 millimeters, which achieves immediate improvement in most patients but durable relief in only about half. And the limitation is that endoscopy treats focal lesions one at a time, so a diffusely diseased gland with a chronically dilated duct has back pressure across the whole system that focal relief doesn't fix. This is where practice changed in dilated duct disease, because the old approach was endoscopy first with surgery reserved for failure, and when patients with painful chronic pancreatitis and a dilated main duct were randomized between early surgery and the endoscopy first approach, early surgery produced more pain relief, and roughly half the endoscopy first patients ended up crossing over to surgery anyway. The mechanism behind that result is that the operation decompresses the entire dilated duct in one procedure. The standard operation opens the duct longitudinally and sews it side to side to a limb of jejunum so the whole gland drains at once, with a duodenum-preserving head resection used when the inflammatory mass sits in the head, and the principle is relief of back pressure across the whole system rather than focally, which is why surgery is now the early move in dilated duct disease rather than the salvage move. The last option is total pancreatectomy with islet autotransplant, reserved for hereditary or small duct disease with intractable pain after endoscopic and standard surgical options have failed, on the reasoning that when the gland itself is the pain source and no decompression can fix the duct, removing the gland removes the source. The key teaching is that islet yield correlates with preoperative pancreatic function, so doing it earlier in hereditary disease, before fibrosis destroys the islets, gives better long-term insulin independence than doing it after the islets are gone, though independence still declines over time, and the combination of postoperative pancreatogenic diabetes and persistent pain from central sensitization limits it to highly selected cases. So the framework lands here. Chronic pancreatitis is classified by cause through the 6 TIGAR-O categories, because the mechanism that converts exposure to fibrosis runs through toxic metabolic, idiopathic, genetic, autoimmune, recurrent acute, and obstructive routes, with obstruction always carrying the must-not-miss of cancer in a patient over 50, and severity graded separately by M. Anheim, more for research than the bedside. The genetic forms each break a different part of trypsin control, the cationic trypsinogen gain of function that drives dominant disease with the cancer risk that earns surveillance, the permissive inhibitor loss that needs a co-modifier, the chloride channel secretion defect that can give isolated pancreatic disease without full cystic fibrosis, and the two modifiers at backup degradation and calcium handling. Diagnosis goes CT first for calcification, secretin MRCP for the duct, endoscopic ultrasound for minimal change parenchyma, and secretin-stimulated function testing for the early gland that still looks normal. And pain is managed in steps, starting with alcohol and tobacco cessation, then non-opioid analgesics, neuromodulators, and enzyme replacement when insufficiency is present, then celiac plexus block and endoscopic decompression for obstructive disease, with early surgery ahead of endoscopy in dilated duct disease, and total pancreatectomy with islet autotransplant reserved for the hereditary or small duct patient who has exhausted the rest. The next episode picks up management once the diagnosis is in. Enzyme replacement dosing by meal with a troubleshooting sequence when response is poor, pancreatogenic diabetes with the insulin and glucagon problems that make its hypoglycemia brittle, the autoimmune pancreatitis types with their distinct demographics and steroid response, and the complications from pseudocyst and splenic vein thrombosis to the sentinel head obstruction that may signal cancer. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 5 of chapter 26, and I'll see you in the next one.